This presentation on the role of central aortic pressure in the management of high blood pressure is provided by Atcor Medical. The presentation is divided into several sections and includes descriptions and data from multiple studies. Data slides include the reference at the bottom of the slide. The publications from the references are available through sites such as PubMed should you wish to read further about the data. I've selected studies based on applicability and general quality, but recognize that they represent a small fraction of all the published literature regarding non-invasive central aortic blood pressure. Please go ahead and skip over slides that don't interest you. However, there may be slides with audio that you may wish to repeat, as some of the analyses, figures, and tables can be considered somewhat complex. The presentation is designed to provide a focused overview while raising awareness of the current and potential utility of non-invasive central aortic blood pressure measurement. The objective of the presentation is to describe the clinical evidence supporting incorporation of non-invasive central aortic blood pressure measurements into hypertension management. I will also describe how monitoring of central blood pressure can guide treatment decisions that will prevent or reduce long-term target organ damage and cardiovascular events resulting from increased blood pressure. The presentation is divided into 5 sections. I will start with background information about hypertension and the need for additional monitoring techniques. The next sections will illustrate how central aortic pressure can predict cardiovascular events, present data showing that threshold values can be defined for central aortic pressure, and how it can be used for management decisions. I will also briefly highlight the issue of white coat hypertension and the role that central pressure measurements may be helpful. The presentation will wrap up with some implications for pharmacotherapy, a summary, and conclusions. Hypertension continues to create a substantial burden on our society. Approximately 45% of adults have hypertension, with hypertension being responsible for approximately 500,000 deaths. Nevertheless, the CDC has documented that hypertension is under control only in 24% of patients. The latter part of this slide shows the economic costs of hypertension in the United States. The diagnosis and management of hypertension is dependent on a reliable cuff measurement of brachial artery pressure. There is no question that the widespread use of brachial blood pressure measurement and the variety of therapeutic options available have led to remarkable improvements in hypertension and associated downstream consequences. Nevertheless, hypertension, as noted in the previous slide, continues to be an enormous health problem. Why is this the case? There are numerous contributing factors which can include suboptimal early diagnosis and case finding, issues related to continuity of care, problems with affordability of care, adverse effects related to medication, poor adherence to medication regimens, and challenges in modifying lifestyle behaviors such as diet and exercise. However, an additional underappreciated problem relates to the current monitoring practices, which rely on accurate and precise measurement of cuff brachial artery pressures. A variety of factors, both patient and healthcare provider, can reduce the reliability and increase variability of peripheral brachial blood pressure measurement. Stepping back, it should be acknowledged that we measure brachial pressure because we have not, on a widespread basis, been able to measure central aortic pressures non-invasively. Central aortic pressures are the pressures that are directly transmitted to the organs affected by hypertension and directly impact end organ damage. Chang and colleagues in the Journal of the American College of Cardiology noted that brachial blood pressure measurement is not so much a surrogate, but a compromised measure that is recorded because of technical limitations. The technique of pulse wave analysis can be utilized to capture central pressures non-invasively. Critical to pulse wave analysis is the understanding that blood pressure is based on the forward pressure wave during systole combined with the pressure wave that is reflected back from the periphery at the various branching points. Pulse wave analysis is able to break out the components and transforms the data from the peripheral blood pressure waveforms into central pressure variables. Among the variables produced are central aortic systolic and diastolic pressure, central pulse pressure, augmentation pressure, and augmentation index. Augmentation pressure is the contribution of the reflected backward traveling wave to the forward wave that has been generated during systole. The augmentation index is the augmentation pressure divided by the pulse pressure. Augmentation pressure and index are important variables that reflect arterial stiffness. Currently, there is only one FDA-cleared medical device for the full assessment of pressure waveform analysis in adults, which is the SphygmoCor device. SphygmoCor is a dual arterial pressure monitoring system that measures brachial pressure and central aortic pressures in the same setting using the same device. Other variables such as subendocardial viability ratio are derived, but for brevity, I won't be describing the specifics in this presentation. The procedure for using the dual arterial blood pressure system is very similar to that used with an automated cuff for brachial blood pressure measurements. The cuff is applied to the upper arm with the patient seated in a comfortable position. The cuff automatically fully inflates and deflates to measure the brachial pressures, which is immediately followed by a partial inflation to record their arterial waveforms. The waveforms are detected by sensing changes in the pressure inside the cuff related to arterial pulsation. The software in the system calculates the various central arterial pressure variables. It is important to recognize that brachial pressures and non-invasively obtained central pressures are not redundant. The figures in this slide demonstrate the point. For example, patient 1, in red, has very similar brachial and central systolic pressures while they are very different for patient 2, noted in blue. Although there is a high correlation between the pressures, they provide additional important information that can be used clinically and should be viewed as complementary. The next section of the presentation will show how central aortic pressure has been proven to predict end organ damage and cardiovascular events. In other words, central aortic pressure can identify at-risk patients such that therapeutic management can be instituted to reduce the risk of future adverse events. It is readily acknowledged and recognized that elevations in brachial blood pressure that exceed well-defined thresholds have been associated with increased risk for end organ damage and cardiovascular mortality and morbidity. The thresholds have been used to define different categories of elevated blood pressure, such as stage 1 and stage 2. Furthermore, treatments that are effective in reducing blood pressure below the defined thresholds have definitively been shown to reduce end organ damage and cardiovascular morbidity and mortality. The figure on the right is the paradigm for treating hypertension recommended by U.S. national medical associations. It bears repeating that damage from hypertension is directly related to the central pressures that are transmitted to vital organs, and that the peripheral pressure is a surrogate measure for those central pressures. The relationship of central pressures to peripheral pressures is significant, with correlation coefficients ranging from 0.6 to 0.97 in published literature. Multiple peer-reviewed publications, including those of meta-analyses, have documented a higher predictive value with cardiovascular events associated with high central pressures relative to peripheral pressures. Therefore, it is intuitive that one of the objectives of hypertension treatment should be to lower central systolic pressures. Targets can be defined for central aortic systolic pressures, similar to that which has been done for peripheral pressure. A very informative study sought to determine the relationship of central and brachial pressures to organ damage. The study was conducted in 1,169 adults who participated in the study. Both brachial and central pressure thresholds were used to characterize individuals. Measures of end organ damage, which included estimated glomerular filtration rate and left ventricular mass index, were documented for each blood pressure group. Stage 2 hypertension, that is, brachial blood pressure of at least 140 over 90 millimeters mercury, was associated with the lowest glomerular filtration rate and highest left ventricular mass index. The middle column is a group defined by normal and high normal blood pressure, with high normal, from European guidelines, corresponding to stage 1 hypertension in US guidelines. This middle column was divided into two groups based on a threshold for central systolic pressure of 112 millimeters mercury. Using a threshold for central systolic pressure clearly differentiated that middle group in terms of end organ damage. The group in the middle with a normal central systolic pressure, less than 112 millimeters mercury, had cardiac and renal function similar to those having optimal peripheral blood pressure, that is, the column on the left, while those with high central pressures, greater than 112 millimeters mercury, had lower organ function, more similar to the column on the right. This study clearly shows how the addition of central blood pressure monitoring can add relevant data determining risk of end organ damage and has implications for treatment decisions. Wang and colleagues sought to determine the relationship of normotensive and hypertensive participants to measures of end organ damage. The measures included left ventricular mass, intima medial thickness of the carotid artery, and glomerular filtration rate. The R values represent the strength of the association. The blood pressure variables used were brachial and central systolic blood pressure and brachial and central pulse pressure, with pulse pressure being the difference between systolic and diastolic pressures. This particular study is quite informative in that it followed outcomes for a period of up to 10 years. All R values were statistically significant, demonstrating an association. However, the strength of these associations, that is, larger R values, were higher with central pressure variables. In the same study, hazard ratios were determined for the association to all-cause mortality and cardiovascular mortality. Both peripheral and central pressures were associated with increased risk. There was no clear distinction in the increased risk between central and peripheral pressures in this initial analysis, which showed that both are important to determining risk. The investigators of the study then further refined the analysis. They performed multivariate Cox proportional hazard regression models that related the incidence of cardiovascular mortality to the different blood pressure variables. The multivariate analysis is particularly useful in that it adjusts for different clinically relevant factors. Model 2 compares central systolic pressure to brachial systolic pressure with adjustments for other variables. In the model, there is an incremental higher hazard ratio for central pressure. That is to say, an increased risk relative to brachial systolic blood pressure. The study confirms that elevated pressures are associated with increased risk of cardiovascular events, including mortality, and that central pressures have a higher predictive value. Several meta-analyses have been published regarding the risk of both central and peripheral blood pressure to cardiovascular events. In this meta-analysis, the authors identified 5 studies where both central and peripheral pressures were documented and the risk calculated. For the figures on the right, the boxes represent the relative risk of the clinical outcome, and the lines are the 95% confidence intervals. The pooled relative risk is displayed at the bottom of each graphic. A value greater than 1 indicates an increased risk, and less than 1, a decreased risk. Statistical significance is inferred when the line does not cross 1. Central and brachial pulse pressures and systolic pressures were associated with increased risk. For pulse pressure, the difference in the risk associated with central versus brachial pressures approached a p-value of 0.05. The authors concluded that elevated central and peripheral systolic pressures and pulse pressure increased the risk of cardiovascular events and all-cause mortality. In 2022, Chang and colleagues published their results of a meta-analysis from a large database of central arterial blood pressure measurements. They sought to define thresholds for central aortic blood pressure that were associated with clinical outcomes and whether central systolic blood pressure, either alone or in combination with brachial blood pressure, improved risk stratification. A total of 5,576 subjects were analyzed. The table is a display of the results. NT is normal tension and HT is hypertension. Hazard ratios exceeding 1 indicate an increased risk. The primary endpoint was a combination of cardiovascular events, cerebral vascular events, and mortality. The middle column represents normal central systolic pressure in the setting of either normal or elevated brachial pressures. An elevated brachial pressure was associated with an increased risk of 1.3 for the primary endpoint. The columns on the right represent the setting of increased central systolic pressures where there is either normal brachial pressures or elevated brachial pressures. There are several relevant interpretations of the data. It appears that central systolic hypertension based on a threshold of 120 millimeters mercury is more predictive of cardiovascular events. The overall conclusion is best stated by the authors where they wrote, irrespective of the brachial blood pressure status, central hypertension increased cardiovascular and cerebrovascular risk, indicating the importance of controlling central hypertension. I would like to now move on to a discussion expanding on how central pressure thresholds can be defined and used for management decisions. The table illustrates 3 different guidelines defining thresholds for hypertension therapeutic decisions. While there is different terminology, the definitions have a lot in common. In particular, all guidelines agree that management decisions for the treatment of hypertension can be based on specific threshold values for both systolic and diastolic brachial pressures, regardless of age and gender. This slide represents a copy of the overall high-level approach to management decisions based on peripheral blood pressure thresholds defined by the 2017 report of the American College of Cardiology and American Heart Association Task Force on Clinical Practice Guidelines. A publication in 2018 evaluated patients grouped according to A, hypertension defined as either having a brachial BP definition of 140 over 90 millimeters mercury or prescribed antihypertensive medications, compared to B, a threshold for central BP of 130 over 90 millimeters mercury or using antihypertensive medications. The authors created a 2x2 table of no or yes for the presence of central or brachial hypertension, as illustrated in the bottom of this slide. The concordance for the presence or absence of hypertension, according to their definition, was approximately 96%. However, isolated brachial hypertension occurred in 2.3% of cases, and isolated central hypertension occurred in 1.4% of patients. While the numbers in terms of percentage seem low, on a population basis, given the prevalence of hypertension, these are significant numbers and have implications for management and economic downstream consequences. The investigators delved further into the implications of discordant cases. An analysis was performed to compare left ventricular mass index and urinary albumin-creatinine ratio, the latter being an assessment of renal function. The results are displayed on the figures on the right of this slide. Isolated brachial hypertension in the absence of central hypertension showed similar and concordant findings in the heart and kidney compared to concordance of normal tension. That is to say, there was no apparent negative effects on organ function. The worst case in terms of end organ damage was when there was both central and peripheral hypertension. The data provides additional evidence that central pressure adds relevant data in determining the risk of end organ damage. The previous slide showed that concordant hypertension was associated with worse end organ damage. Compared to isolated brachial or isolated central hypertension, the adjusted odds ratio for left ventricular hypertrophy with both central and peripheral hypertension was approximately 2. That is to say, the likelihood of left ventricular hypertrophy was twofold that of isolated brachial or central hypertension alone. Similar findings were shown for left ventricular diastolic function and urinary albumin-creatinine ratio dysfunction. The authors concluded that the specific thresholds show clinical utility and that a threshold can be defined for central aortic pressure. It can therefore be inferred that both brachial and central aortic measurements should be reviewed given that treatment decisions often constitute a lifelong commitment to pharmacotherapy. This study, published in the Journal of Hypertension in 2013, was reviewed previously in this presentation. The slide is inserted here to emphasize the utility of using thresholds for central aortic hypertension. In this case, normal versus elevated central systolic pressure was defined by 112 millimeters mercury. Perhaps the most rigorously designed study for evaluation of threshold values was published by Chang and colleagues in the Journal of American College of Cardiology in 2013. The elegance of this study is that they first developed threshold values for prediction of cardiovascular outcomes in a derivation cohort of 1,272 individuals followed for a median period of 15 years. They then tested what they had determined in the derivation cohort in a separate validation cohort. The validation cohort was comprised of 2,501 individuals who were followed for a median of 10 years. The second independent cohort served as a validation of the analysis performed in the derivation cohort. They defined an optimal central blood pressure as being 110 over 80 millimeters mercury. The analysis showed that relative to this optimal central blood pressure, the risk of cardiovascular mortality in subjects with hypertension, defined by a central blood pressure exceeding 130 over 90 millimeters mercury, was clinically and statistically elevated. The hazard ratio of the hypertension versus optimal threshold values was approximately 3, indicating a threefold increase of risk. Their conclusion was that the central BP of at least 130 over 90 millimeters mercury was associated with the largest contribution to the prediction of cardiovascular events. Based on their thorough and rigorous analysis, the authors proposed the following thresholds. Optimal central blood pressure, 110 over 80. Prehypertension, 110 to 129 over 80 to 89. And hypertension as values equal to or exceeding 130 over 90 millimeters mercury. Prehypertension corresponds to stage 1 hypertension, and hypertension as per their definition corresponds to stage 2 hypertension in US guidelines. The graphic on the right shows the sensitivity and specificity of peripheral systolic blood pressure and central systolic blood pressure for predicting cardiovascular mortality in the derivation cohort. The figure illustrates the basis of their proposed values. Additional data from the same study is displayed in this slide. Based on the dataset, the authors determined the central systolic and diastolic pressures that corresponded to the same peripheral pressures that define separate hypertension categories. For optimal and pre-hypertension of peripheral pressures of 120/80, the corresponding central pressure was 113/81. For the category of prehypertension to hypertension defined by peripheral pressures of 140/90, the corresponding central pressure was 132/91 millimeters mercury. The associated cardiovascular mortality rates are displayed in the fourth column of the first table. The table at the bottom shows the hazard ratios for total cardiovascular and stroke mortality in relation to central pressure at entry in the validation cohort. The data show that central pressure thresholds can be used to quantify the risk of these major clinical outcomes. For example, in the middle column of the bottom table, the thresholds for central pressure of 132/91 relative to 113/81 was associated with a threefold risk of cardiovascular death. The authors noted the following in their discussion. In our multivariate model, the results were consistent after accounting for age, sex, and other cardiovascular risk factors. In line with current clinical practice and considering the high clinical events in the age population, we now propose diagnostic threshold of central blood pressure without age and sex specification. The authors also recognize the clinical utility of measuring central aortic blood pressure for the clinical entities of spurious hypertension and white coat hypertension. A study published in 2021 reported the results of a prospective study of 13,461 patients using available central BP measurements and follow-up data from an administrative claims database in Quebec, Canada. The median follow-up was approximately 9 years, for which there were over 1,300 major adverse cardiovascular events, otherwise known as MACE. The hazard ratio for MACE for each standard deviation increase in central systolic pressure was 1.16 and was 1.15 for brachial systolic pressure. When the area under the curve data was modeled for risk, there was a slightly higher hazard ratio using central systolic blood pressure versus brachial systolic pressure that was statistically significant. Sensitivities and specificities for MACE were calculated. Derivations based on the data are displayed in the figures on the right and were used to determine optimal blood pressure thresholds for prediction of MACE. Based on the information, central and brachial systolic pressures of 112 and 121 millimeters mercury respectively were identified as optimal BP thresholds. The next section briefly reviews white coat hypertension and the potential role of central pressure measurements in assisting in suspecting the diagnosis. White coat hypertension is defined as an elevated blood pressure in an office setting with normal values taken at home either through ambulatory blood pressure monitoring or home blood pressure monitoring. The prevalence varies from 10 to 50% depending upon the data source. One meta-analysis estimated the prevalence of 13%. In general, many accept a prevalence of approximately 20%. If the diagnosis is suspected, confirmation is required with repeat office and out-of-office BP measurements. Of note, CMS does provide reimbursement for ambulatory blood pressure monitoring. However, the reality is that the use of ambulatory blood pressure monitoring is low relative to the high prevalence of white coat hypertension. The criteria for blood pressure thresholds for white coat hypertension are summarized in this slide. Several etiologies for white coat hypertension have been proposed. While the physiologic explanation is not universally agreed upon, sympathetic and endocrine factors have been implicated. It is acknowledged that the risk of adverse downstream consequences with white coat hypertension is below that of diagnosed essential hypertension. Data do suggest that the risk of end organ damage may be intermediate between normal blood pressure and true hypertension. The previously described study by you and colleagues also serves as an estimate of the frequency for which white coat hypertension might be diagnosed using concurrent measurements of central and peripheral pressures. The 2x2 table illustrates the concordance and discordance for hypertension and normal tension. In this case, brachial hypertension in the absence of central hypertension was noted in 2.3% of the population. On the other hand, isolated central hypertension without brachial hypertension, inferring masked hypertension, occurred in 1.4% of the population. Integrating both central and peripheral pressure monitoring has clinical consequences as illustrated in the data from the previous study. The graphics show organ function parameters for the heart and kidneys. The first graphic shows left ventricular mass index and the second urinary albumin-creatinine ratio. In both cases, a higher number indicates worsened organ damage. Isolated brachial hypertension, presumably white coat hypertension, shows data similar to the population without hypertension. Evidence of both central and brachial hypertension shows the highest magnitude of organ damage. Isolated central hypertension in this study had a larger impact than isolated brachial hypertension and is somewhat in the middle between normal blood pressure and concurrent hypertension. The data are proof that central pressure adds relevant data determining the risk of end organ damage. Additional data has been generated examining whether information from central blood pressure can help determine the prognosis of isolated brachial systolic hypertension in young to middle-aged individuals. The study evaluated 354 participants with untreated stage 1 hypertension. The control group consists of individuals with normal blood pressure. The untreated stage 1 hypertension subjects had a median central systolic pressure of 120.5 millimeters mercury. That is to say, 50% were above and 50% of the population were below 120.5 millimeters mercury. The subjects were divided into two groups based on that central systolic pressure. The group referred to as low central systolic pressure were those with subjects with central systolic pressure less than the group median of 120.5. The second group, referred to as high central systolic pressures, were those with pressures above the median of 120.5 millimeters mercury. The duration of follow-up was approximately 10 years. The results of the study are shown in this slide. The endpoint was a diagnosis of sustained hypertension requiring antihypertensive treatment, which is a clinically pragmatic endpoint. Please refer to the figure on the left first. NT refers to normal blood pressure defined as a brachial blood pressure of less than 140/90 and therefore not requiring pharmacotherapy. The SDH group had both systolic and diastolic hypertension, that is, a peripheral blood pressure exceeding 140/90 and had the highest probability of requiring pharmacotherapy at the end of the study. The ISH high group, that is, the group with isolated brachial systolic hypertension and high central systolic pressure, had a likelihood of having sustained hypertension requiring antihypertensive therapy that was similar to the SDH group. On the other hand, the ISH low group, that is, isolated systolic brachial pressures with low central systolic pressure, was not different in terms of the endpoint from the baseline group with normal blood pressure. In other words, incorporation of central pressure provides meaningful information in the identification of higher risk populations, which will impact follow-up and management. The figure on the right looked at the same analysis, but dividing subjects into two groups based on an initial central pressure above or below 125 millimeters mercury, and provides a similar interpretation as to that using a value of 120.5 millimeters mercury. The results show that isolated brachial systolic hypertension with low central systolic pressures likely represents white coat hypertension. Another way of looking at the results from the previous slide is to examine odds ratios for developing sustained hypertension for which pharmacotherapy is prescribed. In this case, the control group are the subjects without hypertension. The risk of developing sustained hypertension requiring pharmacotherapy in the ISH high group was sixfold that of the control group. However, the ISH low group, that is, isolated systolic brachial hypertension and lower normal central systolic pressures, had an odds ratio of 1.1, which is essentially no different from the control group. The authors noted that the associations remain significant when the threshold systolic pressure centrally is set at 125 millimeters mercury, and also when the model included ambulatory blood pressure measurements. The investigators concluded that adding central blood pressure measurement in the assessment and management of hypertension is clinically relevant. The previous sections documented a variety of studies with different designs and analyses. While only a small subset of the data in the published literature, these studies demonstrate the clinical utility of including central blood pressure monitoring for the care of patients with hypertension. The next few slides will highlight some of the implications for pharmacotherapy management decisions. The premise of this section is that any prescription of medication should be carefully considered. All medications have the potential for adverse effects in addition to the cost and psychological implications of prolonged requirement for drugs. Pharmacotherapy considerations encompass issues such as undertreatment, overtreatment, compliance, drug cost, adverse events, and drug interactions. For hypertension, initiation of pharmacotherapy is generally a lifelong prescription for daily oral medications. Unfortunately, lowering medications to the lowest required is not nearly evaluated as frequently as it should, whereas increasing medications perhaps is too often prescribed. Increasing medications can also impact negatively overall medication adherence. Therefore, data that can easily be incorporated into a healthcare prescriber's toolbox should be considered. Clinical scenarios are described that address how incorporation of pulse wave analysis into the treatment paradigm for hypertension can provide clinically relevant value to patient care. I want to emphasize that this is not a replacement for brachial blood pressure measurement, but as an addition that is complementary to the current standard of care. Pulse wave analysis can be used for the confirmation of hypertension so that initiation of medication is more likely to be the correct decision for an individual patient. The clinical scenario described is concurrent elevation in both brachial and central pressures. Using the additional information can reduce the likelihood of an unnecessary medication prescription. The second clinical scenario is avoidance of initiation of medication when white coat hypertension should be suspected. Data was shown in previous slides supporting the contention, with the scenario being elevated brachial systolic pressure with normal central pressures. The third scenario is confirmation that increased treatment in a known hypertension patient may not be needed. A common office scenario is borderline high peripheral pressures in the office in individuals with already treated hypertension. It also includes those with additional risk factors where treatment falls on the aggressive side, which is reasonable and appropriate. For these borderline elevated cases, the knowledge that pressures centrally are in the normal range or even low should provide reassurance that immediate increases in medication may not be necessary. This can lead to additional time for lifestyle modification or simply arranging a routine follow-up for a repeat measurement. The last scenario is one that is unfortunately too often not considered. An elevated central pressure with borderline high brachial pressure should cause a prescriber to consider more aggressive treatment. The information from pulse wave analysis and central pressures can be used as a marker of when to consider a reduction in medication. A treated patient with normal pressures is considered well controlled and may then be scheduled for routine follow-up. However, this patient may also be a candidate for a reduction in medication. The concomitant finding of low or low normal central pressures provides a healthcare professional an opportunity to consider a trial of reduced medication. The downstream positive consequences of using the aforementioned approaches have enormous potential possibilities. The BP Guide study is a prospective clinical trial that illustrates the potential of incorporating pulse wave analysis into standard clinical care of patients with hypertension. In this study, 286 hypertensive patients were randomized to best practice using brachial blood pressure management into two groups based on using or not using pulse wave analysis. For the group randomized to best practice plus pulse wave analysis monitoring, specific instructions were provided to the clinical practice based on the values of central pressure. The figure on the right shows the between-group change in daily defined dose of antihypertensive medications for the two groups. The vertical axis represents the change from baseline in the daily defined dose, with time out to 12 months presented on the horizontal axis. The blue line represents the group who are randomized to best practice plus central blood pressure monitoring. The red line represents best practice without having central blood pressure. Statistically significant reductions in medication prescriptions were observed in the active group versus the control group. 16% of pulse wave analysis guided patients had complete cessation of medications versus only 2% in the usual care group. There were no adverse effects on organ function or quality of life in the group who had pulse wave analysis information, despite an overall reduction in pharmacotherapy relative to the control group. The study highlights the potential positive outcomes of incorporating this non-invasive measurement, which can be taken at the same time as brachial blood pressure. The picture on the right shows the changes in 7-day home systolic and diastolic brachial pressures over the 12-month BP Guide study in the usual care and the pulse wave analysis group. There were no differences in brachial systolic pressure. Diastolic blood pressure was slightly higher in the active group at 6 and 12 months, but not in other times, and was still below the threshold of elevated home diastolic BP. There were no relevant changes in office brachial BP, central BP, or 24-hour ambulatory BP despite the changes in prescription medications. Morbidity associated with prescription medications should always be considered by healthcare professionals. In the case of isolated systolic hypertension, particularly if it is white coat hypertension, overtreatment can occur, which may be reduced if additional clinical monitoring is considered. The potential consequences of overtreatment can be considered in two ways. One is the adverse effects that are specifically associated with the medication class, such as cough with angiotensin-converting enzyme inhibitors. The second is the group of adverse effects that are common to all antihypertensive medications, specifically related to the risk of low blood pressure and damage associated with hypotension. Elderly patients are more susceptible to hypotension episodes, including symptoms and potential end organ damage. Studies have documented that there is a bimodal association of blood pressure with cardiovascular events. It is well known that higher cardiovascular events occur when blood pressure is high. However, the converse is true, where episodes of low blood pressure are associated with increased cardiovascular events. Several studies have documented increased mortality in elderly patients that is related to treated hypertension where the blood pressure is low. In older subjects, reduced kidney function has been associated with low blood pressure. It is also well known that older hypertensive patients have an increased risk of postural hypotension, balance and gait disturbances, confusion, and syncope. Other studies have noted an increased risk for injuries from aggressive pharmacotherapy for hypertension. In 2010, Bangalore and colleagues documented the bimodal association of blood pressure with increased mortality in patients with coronary artery disease. They studied 10,000 patients with coronary artery disease who were followed for approximately 5 years. The graphics show the hazard ratios for cardiovascular events on the left and all-cause mortality on the right that are associated with brachial blood pressure. Systolic pressures are on top and diastolic pressures on the bottom. The red line is the hazard ratio, whereas the dotted lines are the upper and lower boundaries of the 95% confidence intervals. This large database clearly shows that there is an increased risk of cardiovascular events and mortality that are associated with low blood pressure, which in this study represented a systolic pressure of 110 to 120 millimeters mercury and a diastolic pressure of 60 to 70 millimeters mercury. A different study published in 2013 evaluated mortality in chronic kidney disease associated with low blood pressure. This was a retrospective study that evaluated data from over 650,000 U.S. veterans with chronic kidney disease. As in the previous study, hazard ratios are displayed on the vertical axis and blood pressure, systolic and diastolic, are displayed on the horizontal axis. Again, one sees evidence of a bimodal distribution where higher event rates are seen associated with low and high blood pressure. The lowest mortality was observed with a blood pressure range of 130 to 159 systolic and 70 to 89 millimeters mercury diastolic. The highest mortality was seen when both systolic and diastolic pressures were concomitantly low or high. Further details from this retrospective study are shown in the table. The rows represent different models that adjust for demographics and relevant comorbidities. The first row represents the unadjusted data. The other rows are adjusted data using different comparisons that are described in the text below the table. The hazard ratios are calculated relative to a reference population with normal pressures as defined in the second column. The first column shows the elevated hazard ratio when there is concomitant low systolic and diastolic blood pressure. A hazard ratio of 1.62, for example, indicates a 62% increase in risk of mortality relative to the reference population. The conclusion here is that patient care must consider the risk of low blood pressure and the implications of overly aggressive hypertensive treatment. Many studies examine broad populations of hypertension patients that exclude patients with significant comorbidities so as not to confound the interpretation of interventional trials. However, given the large burden of hypertension and the enormous population, specific higher risk populations can be examined and characterized. The study in this slide is an extremely important study that was published in the New England Journal of Medicine in 2010. The investigators examined the effects of intensive blood pressure control in patients with type 2 diabetes. The hypothesis was that aggressive blood pressure management should lead to improved outcomes in this particularly susceptible population. A total of 4,733 subjects with type 2 diabetes were enrolled and followed for a mean of 4.7 years. Patients were randomized to either intensive therapy or standard therapy. Intensive therapy was defined as a target systolic blood pressure less than 120 millimeters mercury, and standard therapy was a target systolic blood pressure less than 140 millimeters mercury. The primary outcome was the composite of non-fatal myocardial infarction, non-fatal stroke, or death from cardiovascular causes. The results are displayed in the table. For the primary composite cardiovascular outcome and for the secondary outcome of death, there are no statistically significant differences. It is notable that a higher frequency of serious adverse events attributed to antihypertensive medications were observed in the intensive treated group, and the difference was associated with nominal statistical significance. In addition, the likelihood of having an elevated creatinine, a marker of worsening kidney function, was higher in the intensive treatment group, 23.8% versus 15.5%. The incidence of severe reduction in glomerular filtration rate was 4.2% in the intensive versus 2.2% in the standard group, which was also associated with a very low p-value. Finally, there were more patients with renal failure in the intensive versus the standard group. In the study, the most frequent serious adverse events attributed to blood pressure medications in the two groups are noted in the table, which were, in general, numerically more frequent in the intensive group. The conclusions from the study were that intensive targets for blood pressure control and type 2 diabetes did not confer clinical advantages and were associated with increased risk for adverse events. While this study did not incorporate measures of central blood pressure, it is reasonable to conclude that incorporating central blood pressure monitoring in such a high-risk population may confer clinical benefits both in terms of effectiveness of blood pressure medication and avoidance of potential harmful effects of blood pressure medications. Many studies and data analyses have been reviewed in the preceding slides. Several conclusions can be developed from the data, which I will attempt to summarize. Prior to summarizing, I would ask you to consider that the overall concept being presented is not new. There are a variety of analogies where new advancements have been incorporated to serve as complementary roles and not advocated as replacements. This is very true in healthcare. For example, decades ago, diabetes was managed with urinary spot checks and fasting blood glucose measurements. However, today, no one would manage diabetes without a hemoglobin A1C. This does not replace a single-time measurement of blood glucose, but is used as a complementary diagnostic and management tool. Many years ago, echocardiograms were only available to a relatively small group of academic physicians. Cardiology care in primary practice and in the community relied predominantly on electrocardiograms for rhythm and an evaluation of ventricular function. However, these days the standard of care is electrocardiograms and echocardiograms when there are concerns about cardiac function. For the management of COPD, the basis of pharmacotherapeutic decisions was FEV1. Since 2017, COPD guidelines have incorporated the clinical endpoint of COPD exacerbations in addition to FEV1 for pharmacotherapy decisions. On a day-to-day basis, we now use two-factor identification for standard internet security. In our homes, we often have a deadbolt lock in addition to a regular lock. More importantly, we should try to make a common sense approach to the practice of medicine. No one would argue that blood pressure measurement needs to be correct, accurate, reliable, and confirmed. Brachial pressures and non-invasive central aortic blood pressures should be considered as part of management of all patients requiring care of their blood pressure, and particularly in those with evidence of associated end organ dysfunction. The approach that is being advocated in this presentation has economic implications. Some but not all of the implications are listed in this slide. The positive consequences may include reduced cost, particularly avoidance of medication costs for treatment when treatment may not necessarily be physiologically indicated, reduced costs related to avoiding medication adverse effects, earlier treatment based on concurrent elevations of peripheral and central pressures that would hopefully reduce long-term morbidity, and guidance for instituting trials of medication reduction in appropriately characterized patients based on their central and peripheral blood pressure measurements. Continued investment in research is ongoing due to the recognition that hypertension continues to be responsible for high socioeconomic costs despite the widespread availability and use of cuff brachial artery measurements. It is readily acknowledged that the widespread availability of brachial blood pressure monitoring has contributed to reduced morbidity and mortality from hypertension, but we should strive to continue to improve on these outcomes. The data in this presentation from multiple publications demonstrate that elevated central pressures predict cardiovascular events, mortality, and end organ damage. While central blood pressure measurements are correlated to brachial systolic pressures, brachial pressure does not reliably predict central pressures. These measurements are not redundant and should be considered as complementary. The risk of adverse outcomes with elevated central pressures has been shown to be higher than the risk associated with elevated brachial pressure in multiple publications. Importantly, central pressures have been shown to be independently predictive of cardiovascular events and therefore provide additional risk information. The overall conclusion is that monitoring central pressure with the target of lowering elevated central systolic pressures is anticipated to reduce the risk of cardiovascular events and organ damage. The utility of incorporating central pressures into everyday management decisions is linked with the ability to define threshold values for the diagnosis and treatment of elevated pressures. Such threshold values have been defined in studies. As in the previous slide, the incorporation of central pressures in hypertension management has several advantages that are noted in the statements in this slide. The overall conclusions from this presentation are as follows. Incorporation of central aortic pressure monitoring, which is complementary to continued reliance on brachial pressure monitoring, should be a part of the care of all patients with hypertension. The dual arterial pressure sphygma core system provides both central and peripheral pressures in the same office space setting and therefore represents a cost-effective addition to blood pressure management. The remainder of the slides represent an appendix to the presentation. The next section outlines a proposal on how to incorporate threshold values for central aortic blood pressure that can be part of current blood pressure guidelines. The guidance using brachial blood pressure from the 2017 U.S. guidelines is shown in this slide. The figure from the previous slide has been broken down and expanded for ease of reading. A variety of variables that are derived from pulse wave analysis can be used for the understanding of hypertension and evaluating risk as well as management approaches. For practicality, the focus of the proposal is restricted to the use of central aortic systolic pressure. Certainly, other information from additional variables is important. The threshold values for central aortic systolic pressures are proposed as follows. Normal being less than 113 millimeters mercury, elevated or stage 1 hypertension, 113 to 129 millimeters mercury, and stage 2 hypertension, at least 130 millimeters mercury. Slides 61 to 64 superimpose central pressure targets into the 2017 ACC/AHA guidelines. The slides are self-explanatory and no voiceover for these slides is being provided. The last slide has been included to indicate that a CPT Category 1 code is available for arterial pressure waveform analysis. This concludes the audio portion of the presentation. More information can be found and obtained at the AdCor Medical website.